Good morning, dear BCMCH family. Welcome to one more Quest session. And it's a great privilege to have all of you here at the amphitheater. Before we start our proceedings, may I request our dear Chaplain Achin, Reverend Father Thomas Verghese Achin, to start with a word of prayer.
Shall we all stand for the prayer, please? In the name of the Father, Son, and the Holy Spirit. Amen. Our gracious Heavenly Father, we thank you so much for this second Thursday of this November 2023. What a privilege for us to be here in your presence this morning, to hear something new, to hear what the Lord is doing in the midst of our people. How you are using your servants for your glory. Everything possible with you, we read in the Bible. It is happening here in this campus. One more time, Lord, you encourage each one of us through your servant, Dr. Finny, and it will be beneficial for each one of us in the coming days as well as these days, wherever we are walking. We thank you for answering our prayers. In Jesus' mighty name we pray. Amen. Please be seated.
Yesterday, I was at a government meeting in the National Health Mission, and sitting next to me, I was chairing a session which the person next to me was a person who was the head of the Department of Community Medicine at PGI Chandigarh. And as part of his keynote address, he started off by telling us how great his institution is, how it's the best institution in the country, and then seeing me sitting next to him, he added All India Institute and CMC. They are also very good. But the pride with which he spoke, he wasn't saying it for the sake of saying it. His talk was not on PGI at all. So I believe that the culture of an institution where we not only work with each other, love each other, build family community, there's one more aspect of it. That we are proud of who we are, what we are, where we are. And I can add this. The first 5 years when I was here, I always used to introduce myself wherever I go as I'm George Chandy from CMC. The last 4 years I've been saying I am George Chandy from Believers, because I've begun to become proud of my institution, and I believe that it is one of the best and that we will grow to become even better than the best. So today we are welcoming 6 people who, when they joined us, I guess they thought only about themselves. That's what we all do. We think about ourselves, our future, how working here will help us in our own journey. And then gradually, when they became assistant professors, they started looking around, saying, oh, there are other people around me, so let's start thinking about them. So if you're in a unitary system, you start thinking about a unit. And as you become an associate professor, you think a little more about the department. And when you become professor, you start thinking about the institution as a whole and its relevance, its place in the world. So I'm happy to present to you 6 people who I've made them vow that they will do all this. They will take off a lot of my responsibilities. They'll take up a lot of things that I do and make a huge difference, not only within the community, to the students, to the faculty, to the staff, and also the world at large. So first of all, I'm happy to welcome Professor Abraham Matthew, and I'll request our principal, Dr. Girija Mohan, to please come forward and honor them, each one of them. Ma'am, Abraham Matthew is professor of surgery, and recognizing his talent and abilities, the department has made him head of the department of Unit 4 along with Jordan Thomas and Sariga. He did 3 years in the surgical endocrinology department in CMC before the course started. So though he doesn't have a degree, he's done everything that is required. So he will work closely with the breast and endocrine unit as well. So welcome, Professor Abraham Matthew. You know that Dr. Jitin Abraham Matthew is an excellent anesthesiologist. You know that he's a great communicator. You know, but you don't know how technically brilliant he is. So all the problems, or not all, lots of the problems in anesthesia, he sorts it out. I've been to his home and I've seen so many beautiful gadgets, the making of which the children try to disfigure it, but then he goes back at the end of the day and sorts it out. Technically very sound, brilliant, and I hear that Kottayam Medical College tried its best to keep him there, and we are privileged to have Jitin with us. So it's not only singing talent, but also a whole lot of other talents that as professor he will give to us. So I'll request Dr. Girija Mohan to honor Dr. Jitin Matthew Abraham, Professor of Anesthesiology. There's one doctor who never gets fed up of seeing patients. He comes at 7:30 in the morning and he is here till the last patient is seen. I've actually gone into his OPD and tried to understand how does he do this, because I get tired when I see the 40th, 45th patient. But this guy can go on, sorry, I shouldn't say guy. This doctor can go on till 55, 60, 65. Over the years, he's been wonderful as a communicator, as a patient. A whole lot of patients who come back and say, we want to see Dr. Sunil Antony. He is now Professor Sunil Antony. Sunil, please come forward. This is an exceptional talent that you have, and your willingness to always go the extra mile for your patients, for the institution, as Professor in Medicine, of Medicine. We bless you. Someone who writes books, who ensures that children, the students are taught how they should teach. Recently there was a complaint from the 2023 batch saying that we don't know how to study because we've only studied for NEET, which means we've only mugged up. We don't know anything. Please teach us how to teach. So as soon as she heard it, along with Annama ma'am, they called a meeting of the students. They got a feedback from them. You got things written down beautifully. And before we realized it, Dr. Indira and her team, along with Dr. Annama, have really created a new system for the medical students in physiology. We welcome Professor Indira N. Dr. Anu C. John has quietly over the years been working towards establishing a good system of teaching and education in the Department of Biochemistry. Very often she's been a lone ranger, but today now she has Kannan with her. But over the years, Anu, thank you for the good work you've done, and I'm sure from now on you will take further steps for biochemistry, for the department, for the institution. Welcome, Professor Anu C. John. We have someone who is known internationally and is a lone scholar, and she made a presentation 3 weeks ago here about how she was welcomed, how she did it, and gave us all advice as to how we can do better, be better than the best. So we have amidst us someone who has excelled in community medicine, but also has done so many newer things in the area of research, which is a model for us. And I'm sure that though Dr. Sarita Susan Verghese has been with us only for a short period, she will now develop into a person who helps believers to be better than the best. I welcome Dr. Sarita Susan Verghese, Professor of Community Medicine.
Good morning. I would like to take the opportunity to welcome Dr. Dennis Titus, joining MD Radiodiagnosis as senior resident. He's completed his MBBS from Government Medical College, Kottayam, and his areas of interest are conventional imaging, ultrasonography, and he's a second rank in MBBS in MG University and fifth rank in MD in Rajiv Gandhi University of Health Sciences. Welcome, Doctor. I'd like to welcome Dr. Sijin Prem S, Senior Resident in General Surgery. Completed his MS General Surgery from Amla Institute of Medical Sciences, Thrissur, and MBBS from Government Medical College, Ernakulam. His areas of interest is in hernia and thyroid surgeries. So welcome, Dr. Sijin Prem. Thank you.
Today's speaker is an erudite scholar, a clinician par excellence, an amazing researcher, and a great human being too. He completed his MBBS from the prestigious CMC Vellore, took a great liking to the institution and went on to complete his MD in General Medicine and DM in Endocrinology, and further trained in the UK for a fellowship, Royal College Fellowship, came back to India, took heart for the masses, went out into the real Bharat and served the community in various mission hospitals and primarily at the Duncan Hospital, Roxall. In 2017, it was a great privilege for us as an institution to welcome him and to have him as senior consultant and head of endocrinology. He has keen interest in research and has guided so many of our students into the world of research, and he has been instrumental in organizing the SHP program and sending out our students again into various mission hospitals for training. So can we all put our hands together and welcome senior consultant and head of endocrinology, Professor Dr. Philip Finny. Over to you, sir.
Good morning, dear colleagues and friends, students. This morning what I intend to do is to share with you two patients who came to us in the last 3 to 4 months who had diagnosis delayed for a long time because it was not very evident. They say that we can usually pick up common presentations of common illnesses. Uncommon presentations of common illnesses are much more common than common presentations of uncommon illnesses. But here we have a patient actually who's got uncommon presentation of an uncommon illness. And actually that notice was slightly titled differently. But I want to tell you about a young gentleman and a young lady who came to our institution for help. And it was truly an interdisciplinary effort from multiple departments in this hospital actually, which helped us to pin down the diagnosis and to help them get over their problems. And so I want to reveal this over time. I've also requested Team Pathology. Dr. Elizabeth Joseph has requested two of her postgraduate students to share with us the pathology slides, because the final diagnosis is ultimately with the pathologist. And so I want to appreciate the help, the pathology department, Department of Endocrine Surgery, the Department of Medicine, and the orthopedics department, who have contributed significantly in us arriving at this diagnosis. So over the next 30 minutes, we hope to run through this in 15 minutes each. And I would request you, if you can reserve your questions till the end, then we could have a discussion. So this I've labeled as, first gentleman is a patient who came with diabetic ketoacidosis. He was a 37-year-old IT professional who works in Bangalore, who came to the Believers Rural Urban Health Center in Koni unconscious. He was diagnosed at Koni to have diabetic ketoacidosis with a dangerously low pH on ABG. The pH was only 6.8. He had a metabolic acidosis and he was very sick. At Koni, our team there did a wonderful job. They gave him IV fluids, insulin, corrected it, but they realized that he had many more problems and they needed a more precise treatment. And so they referred him to us after stabilization at Koni, and he arrived here on the 26th of September evening. And the history was that he's actually known to have diabetes from the age of 33 years and has become very non-compliant with medication. He has developed a mistrust of doctors and medicines because he feels his medicines poison his body. And so he had stopped taking his medicines for 3 to 3.5 years. The only period he took medicines was for about 6 months in between with oral hypoglycemic agents. He had also mentioned on deeper questioning by the medical team that he did have some palpitations and some breathlessness for about 3 to 5 days before the presentation. No vomiting, no abdominal pain or fever. But he had been admitted in Muthoot Hospital 2 years ago with diabetic ketoacidosis and had fortunately come out of it, which we know is a life-threatening illness. Medicine 4 team was on call that day in the casualty. They promptly handled the patient very well. He was admitted in the ICU. As you can see, he had severe metabolic acidosis. His blood ketones and urine ketones were positive. His HbA1c, as you can see, is sky high. It's 12.1%, showing extremely poor diabetic control. His potassium was very low, less than 2 initially. His phosphorus, which we normally don't check, was less than 1 for 2 days. That is one of the markers of the extreme severity of DKA. Very rarely do we correct phosphorus in a patient with DKA, but it took about a day or two for that to get corrected. In the ICU, he did improve with insulin infusion, IV antibiotics, and he was given IV fluids. He received potassium, phosphorus supplementation. And because his CRPs and counts were high, the treating team suspected whether he had an infection. And he did mention of some abdominal discomfort. So he had already had a CT scan when I was called in, because to their surprise, they found a large adrenal tumor sitting on the left adrenal gland. And the question was, what is this adrenal tumor? And that is almost serendipitously this diagnosis picked up, because it was not expecting that we'll pick up a adrenal mass. The CT abdomen showed a large 6.5 centimeter lobulated lesion sitting astride the left kidney, and it was heterogeneous in appearance. This is the picture, and if you see the slide, can you see this one? That is a 6.5 to 7 centimeter lesion of varying ecotexture, seems to have areas of necrosis as well in the particular slide. And this was to us when we were called in one evening. It was the end of the OPD, tiring day. At 6:30, I go, and to my surprise, to me, it's nothing else but a pheochromocytoma, which we don't often make a diagnosis of, because the appearance, the clinical presentation all seem to suggest it is likely to be a catecholamine secreting adrenal tumor. So he was continued to be cared for by the Medicine 4 team for the next few days because he needed a lot of care and intensive support. And we suspected him to have pheo, and we started him on alpha blockade because of severe vasoconstriction. You want to try to slowly get the patient stabilized, because we know surgery is the only way we can probably cure this patient. So we put him on prazosin and gradually built up the dose to about 10 milligrams twice a day over the next 3 days. Over the next 2 weeks, we monitored his blood pressure. For the sake of the students, we generally tell hypertensive patients to restrict salt, But this is one condition where you have hypertension. We tell them take plenty of salt, plenty of fluid. The whole idea is that these people are intravascularly very depleted, and we want to build up the intravascular volume before we take them up for surgery. Otherwise, they can have a crash in blood pressure, and it will be a nightmare for the anesthetist. And relevant lab investigations were sent, and we sent the urinary metanephrines and the plasma metanephrines. I don't know how many of you can see. The metanephrines normally should be less than 300 in the urine, 24-hour. The value is 600. But can you see the normetanephrines? In the urine, it is about 4 times the upper limit of normal. The plasma metanephrines are even more striking. You can see that the free normetanephrines is 4,900, whereas the normal should be well below 130. So you can see that the normetanephrines and the metanephrines were very high, predominantly normetanephrines, suggesting it's probably an extraadrenal pheochromocytoma or a paraganglioma. Incidentally, sometimes our CT scans go a little bit beyond the area of interest. The CT scan stopped at the thigh, and to their surprise, they also reported not just an adrenal pheo, they found there was an ill-defined lytic sclerotic lesion in the proximal right femur, and we requested the orthopedic team to comment on it. Dr. Vinu Cherian had a look at this, and he said probably it looks like a chondrogenic sarcoma or probably an enchondroma. It looked very, very suspicious, and with 6.5 centimeter lesion sitting in the right proximal femur, for which the patient had no complaints whatsoever. So this is picked up incidentally. Dr. Tom George, who's seated here, helped us with the CT-guided biopsy before we went. We want to know if it's a metastasis or if it's some other primary bone tumor. Unfortunately, the CT-guided biopsy didn't show anything definite, and so the pathology team and the orthopedics teams suggested that we should do an open biopsy when he goes up for the surgery and anesthesia for the adrenal pheo. So this is the lesion, and I'm showing you the arrow. Can you see this lesion in the proximal femur? And you can see the cross-section, the same tumor seen in the proximal femur. And this looked very suspicious, and Dr. Vinu was very worried. What are we dealing with? Is it another primary bone malignancy? The MRI was also done as per the request of the orthopedic team. It showed a 6.4 into 3.7 centimeter tumor in the right proximal femoral shaft. So this made the patient even more interesting as a puzzle for us to crack what is happening. The endocrine surgery team, and supported by Dr. Sujit Philip from the gastrosurgery team, came in and planned for his laparoscopic adrenalectomy, which is done not very commonly here. And the left adrenalectomy was done after a lot of multidisciplinary team meetings with the team anesthesia, who supported us in the planning, the management. And many times Dr. Ashu and team came over and saw this patient. The patient, as you know, is always a skeptic. He doesn't trust any of us. Over the 2 weeks, it took a lot of confidence building, talking to him many hours, in fact. And my team was a great support, especially he fell in love with my senior resident, Dr. Rinto. He says he's the most caring doctor he's come across. And he really did a great job in supporting him psychologically before he went for this, along with Dr. Anju Francis. They both regularly did the evening rounds and supported him. And after that, Dr. Anish and Dr. Sujit operated on him. They started off with the laparoscopic method, but because of some bleeding, once the vascular clips were put in, they had to convert to an open surgery, and the open biopsy of the right femur lesion was done, wanting to know what exactly this is. Patient recovered very well. As I didn't mention before, he was requiring nearly about 60 to 70 units of insulin pre-op, and after the surgery, his insulin requirement disappeared. His diabetes was cured. His blood pressure was 160, 110 on 3 antihypertensives. Now he's without any BP medicines. And it was so wonderful to see him. Of course, before he went, we put him on a tiny dose of amlodipine and sent him home. And he came back for the last OP review last week. And Dr. Anish was telling me he's doing much better. In fact, the insulin is going just at a tiny dose because we don't want him to go into another DKA. So we've kept him on just about 10 units of insulin. But it was so gratifying to see a secondary cause of diabetes. We found a root cause, and for 4 years he's been through many doctors in Bangalore and in Kerala in some of our premier hospitals, but somehow this was not picked up. The fact that, and probably we were also very fortunate, I must say, because he did have some infection, and in the search for infection is when actually the CT was done to look for pyelonephritis. I was just going through the notes yesterday with one of my colleagues, and we found that actually Dr. Felix was assisting me from Medicine 4, and we looked up, and actually the reason we did it was for looking for pyelonephritis, but we found an adrenal tumor. So it is good God's grace, I think, which is there when we prayerfully handle many of these patients. The patient has gained 1 kg of weight even before he went discharged. And one of the things with pheo is it's a catabolic state, so many people lose a lot of weight, and he's now doing well. And this is the biopsy report from Dr. Elizabeth and team. This is the adrenalectomy specimen, and that showed there was a lesion, and that is adrenal lesion is a pheochromocytoma, and the proximal femur lesion, there was no evidence of metastasis in the given material. So I'm going to request Dr. Minu. She will just show us the slides to make the presentation complete in that sense, and then we will just go take the carry home messages and go on to the next patient, which is from team orthopedics, which we helped. Yes.
Good morning to all. I am Dr. Mindu Elsa Verghese from Pathology Department. I am second year Pathology PG. So I'm starting my presentation.
It's not projecting.
So we received in our department left adrenalectomy specimen, and this adrenalectomy specimen was about 7.5 into 5.5 into 5 centimeter in size, having about 94 gram weight. And the first picture shows an intact adrenalectomy specimen, and the second picture shows the cut surface of it. We can see a cut surface of a well circumscribed encapsulated lesion, having a yellowish to brown color in cut surface, and focal areas has showed hemorrhage. And now to the second picture. Now I'm telling about the histopathology or the microscopy of this lesion. So the upper portion, of the portion shows a normal adrenal medulla, and the lower portion shows the neoplasm. And there is a thin capsule surrounding it. This is the upper portion, which is showing the normal adrenal medulla, and then the lower portion showing the neoplasm. And this is a magnified view of the neoplasm, showing the arrangement of neoplasm. The neoplasm are being arranged in cell ball and pattern, that is nest-like pattern, small nest-like pattern, which have been surrounded by cystentacular cells. So these are the individual nest tumor cells which are being arranged, which is each individual nest tumor cells. And then this is the magnified view. And these individual tumor cells, we can see each of them has got a pale amphiphilic cytoplasm and central round nucleus, and some of them are having prominent nucleoli. Now to the next image, and this is showing vascular invasion of the tumor, and the pointer has been used for that tumor cells which are being seen in the blood vessel. So the morphological DDs we considered were pheochromocytoma, adrenal cortical adenoma, and adrenal cortical carcinoma. The features we see in pheochromocytoma are mainly nested or cell ball and arrangement, nest outlined with cystentacular cells. So as the image shows, we can see in the upper portion a well demarcated border which is delineating the normal adrenal medulla and the neoplasm, as I told earlier. And then below that we can see the neoplasm arranged in cell ball and pattern. And each of these nest tumor cells, each of these tumor cells has got round oval nuclei with prominent nucleoli and having abundant fine granular red-purple cytoplasm. And each of these nest tumor cells have been surrounded by cyst and agar cells. Now the adrenal cortical adenoma. Adrenal cortical adenoma, we can see the arrangement in cords, nest, and the picture has been projected is of the adrenal cortical adenoma showing individual tumor cell features in which each of them are having distinct cell borders, having abundant foamy cytoplasm, which has been seen in lipid-rich adrenal cortical adenoma. And in case of lipid-poor cells, these each cells will be having eosinophilic cytoplasm. And our third morphological DD was adrenal cortical carcinoma, which has got solid arrangement, broad trabecular arrangement, and large nested arrangement. And the important factor is adrenal cortical carcinoma shows invasion of thick fibrous capsule, lymphovascular invasion, and areas of necrosis are common for them. And also the individual tumor cell shows granular clear to eosinophilic cytoplasm having pleomorphic feature. That is, there will be variation in size and shape of the cells, and we can also see increased mitosis and atypical mitosis in them. And in this case, in our case, we can see nested or cell ball and arrangement of the tumor cells. Each of these nest tumor cells outlined by cyst and agar cells. And each of these tumor cell has got fine granular cytoplasm, which is basophilic to amphiphilic cytoplasm, having round to oval nuclei with prominent nucleoli. And there was no capsular invasion, no necrosis, and no increase in mitosis, but there was vascular invasion. So we came to the impression of left adrenal gland adrenalectomy specimen of the final diagnosis of pheochromocytoma, having a size of 7.5 into 5.5 centimeter, showing vascular invasion, and margin was free of neoplasm, and pathological stage classification of PT2, which is mainly based on size of the tumor. Since the tumor size is greater than 5 centimeter, we gave it as PT2 stage. And this is the second biopsy we received, that is a right proximal femur bone curating, in which we only got fragments of bone and fibromuscular tissue. The second image is of the smooth muscle fibers we got. And the next image is a magnified view of both of them. The first image shows the magnified view of the bony fragment showing a lamellated bone having osteocytes. And the second image is of that of muscle fibers, elongated muscle fibers having elongated nuclei, and striations were found. So the final impression was that there was no evidence of metastasis in the material we received, so probably it must have been taken from the periphery of the lesion. Thank you.
That's fine.
ഇതിനകത്ത് മാറ്റിയോ സാറോ ഇതിനകത്ത് ഓപ്പൺ ആക്കിയിട്ട് ഇതിനകത്ത് മാറ്റാവുന്ന സ്ലൈഡ്
ഇപ്പം നെക്സ്റ്റ് എന്തോ ചെയ്യേണ്ടത്?
ഇത് ഓപ്പൺ ഇതിനകത്ത്
ഓപ്പൺ ആണ് വരുന്നുണ്ട്.
വായിക്കണം
ബാക്ക് സ്ലൈഡ് ഇതൊന്നും ഇവിടെ
ഇതങ്ങ് മാറ്റിയാൽ
Yeah.
മതി ഇതാണോ
ഇതല്ല നെക്സ്റ്റ്
ഇവിടെ അടിച്ചാൽ മതി
Okay, that's fine. Yeah. So, 6 years ago, as Jacob was saying, I was in England doing the fellowship of the Royal College in one of the university hospitals there. And you won't believe it, I was called just like this into the ICU of the coronary care unit in that hospital in the Essex Cardiothoracic Center. The cardiologists had treated a patient with acute coronary syndrome, but to their surprise, they found this patient had a normal angiogram. And they labeled it a type 2 myocardial infarction. And they didn't know why this patient had a severe vasospasm causing this MI. And he was very bad. His echo showed an EF of 30% and they were puzzled. And we were called in because he developed severe abdominal pain in the ICU and they did an imaging. And to their lo and behold, to their surprise, if you can go and Google this, some of you can Google this BMJ case reports in 2016, you can put in FIO, you will see it was a large right adrenal tumor which was found out. And that's when as endocrinologists we were called in. You won't believe sometimes God orchestrates experiences in our life so that when we see another one, unless you see one, you don't recognize the other one. It was a large adrenal FIO. And later on, we had stabilized the patient. He went to the University College London in the Royal Free Hospital, and there he had his adrenalectomy a few months later. So this we had published it along with my colleagues at the UK. And you won't believe, this patient had come to us not only in cardiogenic shock, but he had hyperosmolar, hyperglycemic hyperosmolar state. His sugars were 500. So this is like a déjà vu, same story happening again in a different form. It's about 6-7 years later. And that patient had a very different story, and I was telling the medical students, if you just Google in this particular details, you can read the whole story. And that patient did very well, and the patient has written his own perspective also in the BMJ. So what do I want to carry home? I realize that we are running short of time, so we will stop with this present. Next patient is even more fascinating. Maybe we'll discuss it another day because I think we won't have time for questions for both. So this is a very unusual patient. Dr. Anulekha and me, we were looking up how commonly does FIO come with the initial presentation of DK. Extremely uncommon. DK we treat all the time in medicine and endocrinology, but rarely do we see the root cause being a reversible cause like a pheochromocytoma. The bony lesion, could it be metastasis or an unrelated lesion? Last week I had to go to Vellore for an emergency for one of my family, and there in our endocrine nucleus medicine surgery meeting we sat together and actually we discussed about this young man, and they were wondering what is the best thing to do, and we realized perhaps the next step to move forward is to do a good nuclear medicine imaging to see if this lesion in the bone by any chance is it a somatostatin receptor affinity tumor, SSTR2 and 5. So we were thinking next of doing a gallium dotatate scan or an MIBG scan. MIBG is not being done at Parumala Hospital regularly, so we are thinking of doing a gallium dotatate scan. One point which in the textbooks don't mention very often is that weight loss is a significant feature of pheochromocytoma, and that's what this gentleman had lost a lot of weight. He was really very skin and bones probably in a sense. We had also wondered if he's got a type 1 diabetes, and we had done a GAD65 antibody that was negative in this gentleman. So it sort of confirmed that this gentleman has got pheochromocytoma itself being the cause of his diabetes and his hypertension. And it's so nice to find a reversible cause when you can get rid of it and his diabetes is cured. We needed to exclude MEN2, multiple endocrine neoplasia, and von Hippel-Lindau syndrome by genetic screening. So we had done a tumor marker, the calcitonin test, which is negative, and his calciums were normal. So that made MEN2 very unlikely. And he didn't have any of the clinical or the radiological features of a von Hippel-Lindau syndrome. Lifelong follow-up is needed for many of these patients. Nowadays, genetic screening has come in a big way in the management of pheochromocytomas. We know that the succinyl dehydrogenase genes, SDH genes, are checked. If, for example, if you have SDHA, SDHB mutation, some of these have a poorer prognosis, some have a good prognosis. But sometimes metastasis may present much later. I am indeed worried by the pathology report saying there's a vascular invasion, but the PAS score, which is the pathological scoring system to say if it's likely to be benign or malignant, Dr. Elizabeth and myself were discussing, it seems to be unlikely it's a malignancy, but the proof will only come as we follow up the patient. So it's important that the story is not over yet. We have to continue following up this patient. So those were some of the interesting things, and I wanted to present to you, my dear friends and colleagues, a reversible cause of diabetes. Isn't that wonderful? Amidst the pandemic of diabetes we are seeing right now, to keep our eyes and ears open for something reversible. It does come very infrequently, but I'm sure maybe somebody in the audience, maybe among the students in your time, in your practice, you may remember this patient and perhaps the other patient I alluded to pick up one or two of these patients, and for them it can be life-saving. Thank you very much, and we'll have the questions, and I've been requested to have time for questions, and then we'll do the other more interesting presentation at the next, another forum. Thank you very much. Are there any questions? I think my entire team here, Dr. Anish, the endocrine surgery team, Dr. Ashu and team from anesthesia. I'm not sure if the orthopedic team is here, but Dr. Tom George is here from interventional radiology who helped us. Team pathology is here in its full strength and might. Dr. Elizabeth said we are all going to be here to support and the questions in pathology. Any questions from the team? I want to thank all of them. Can we just give all of them a big hand? And to Medicine 4. Medicine 4 is, I think, the best specialty because they are the ones who brought this entire thing together. I also want to thank team surgery. You won't believe, they couldn't catheterize the patient in the ICU. They found that he had a phimosis. They had to do a dorsal slit and paraphimosis, and they catheterized him. And even team surgery 1 was involved in the care of this patient, and we have to plan a circumcision later. Thank you so much.
Philip, thank you so much for that presentation. Many people ask me when I say we should be the best, what does it mean? This is a clear example of being the best, because this cannot be done in most other places because you're fighting for your patient, you're not working together as an MDT. So the fact that all of you work together to make this diagnosis, very unusual diagnosis, so hats off to each one of you and thank you very much. This is one of the reasons I say we should be the best, and this is what we do. My one question is, in terms of management from now on, he's not a diabetic anymore. So all that is off?
Yeah, his antihypertensives are off. He's off, and he's actually on a tiny dose of insulin because we want to keep him on that. His sugars are actually going on the low normal side. We're planning to take off the insulin perhaps. But the follow-up is, I'm more concerned, I think he may have some residual hypertension because his hypertension probably has been going on for a long time, and he may have developed some renovascular changes. So we'll have to watch his blood pressure and sugars slowly, but I think it's unlikely he's going to require the large amounts of insulin which he needed because we've taken off the source. The second thing is, I think the follow-up is now going to be see whether he will develop any metastasis. And Dr. Vinu Cherian, who is not here, he had suggested perhaps we should have a proper evaluation of the bone lesion again after we do a nuclear medicine imaging. We want to see if that lesion in the bone takes up any of the gallium or the MIBG. If it does, then we have to go for either MIBG ablation, which is a therapeutic dose, or we go for lutetium-based treatments, which are a bit expensive, but that will be what will be eradicate this particular lesion. But it's going to be a long-term, in fact, a lifelong follow-up for this gentleman. What is his relationship with you now? Yeah, so right now I think he's developed a loving relationship with Dr. Anju and Rinto, and also with us, but we were just privileged because our junior members of the team actually did a great job of relationship building, and he really has a change. Actually, he was very, very negative. In fact, Dr. Mohan Verghese and myself, we in the ICU, we took an undertaking that he will not run away. He said he's getting discharged the next day, he was well from the ICU. So we got a written, bold letter undertaking that he will not, it looked like he may create problem. But the key was to win over the hearts of the family. And we sat down with the family that evening at 6:30 and had a long, detailed discussion. And his sister. But now I think the family has really gelled and bonded with us. Dr. Anish and team also spent a lot of time before surgery to sort of build relationship. And I think that is what led to the success of the care process. Any questions from any of you? We have 5 more minutes. Multiple endocrine neoplasia type 2, ma'am, has got medullary thyroid cancer, pheochromocytoma, as well as hyperparathyroidism as type 2A. So we screen for any of them because he's a young man less than 40 years. So if any of the one tumor comes, if this triad and before 30 years, you must watch out for the other tumors and you must screen. We do a serum calcitonin as a test for picking up MEN2. And we did a serum calcium as well.
Philip Finny is actually, I almost heard, ഇത് തന്നെ സെയിം സാറ്റർഡേ ജേർണൽ ക്ലബിലുണ്ടായിരുന്നു ഇല്ലേ, മയോകാർഡിയൽ ഇൻഫെക്ഷൻ അല്ല മയോകാർഡിയൽ ഇൻഫെക്ഷൻ BMG. So I think that as 2 years I am here, your field is, one is hypercalcemia, hyperparathyroidism, another one pheochromocytoma.
Yeah, that's our bread and butter, ma'am. Yes, any other questions from the floor? Yes, Dr. Shah.
So one of the important clinical clues that it's a malignancy is the evidence of pallor. Is the patient is pale on clinical examination?
So his HB, sir, when he came in for decay and dehydration was 14.4. But after he was well hydrated, it actually dropped to 9. So it is a gross drop beyond what we expect with just hydrating. So thereafter we did a detailed workup for his anemia. His iron levels and transferrin levels were very low. So he just had anemia of chronic disease is what the reports seem to suggest. So we had the hematology team also collaborating with us. I didn't mention them. But the final conclusion is anemia of chronic disease. HB has climbed after the surgery. It has already climbed to above 10. Thank you, sir. Yes, Dr. Abraham.
Thank you, Philip, for this unusual case. Very good eye-opener for us all. I was just wondering, you said this was a reversible case of diabetic mellitus, but in my mind, usually I think of Cushing syndrome and relation with diabetics, but I'm unable to correlate how pheochromocytoma could cause diabetics.
So, pheochromocytoma, Dr. Abraham, causes a surge of catecholamines, and we know that insulin and the other counter-regulatory hormones are in a balancing act. If insulin is on one side, all other counter-regulatory hormones, the growth hormone, the glucagon, the cortisol, and the catecholamines on the other side. So if you have this balance is tipped over when you have a catecholamine surge. So catecholamine excess can also lead to hyperglycemia. It's described in pheochromocytomas. Because we have epinephrine surge, right, when you have a hypoglycemia as a way to counter the hypoglycemia. Yes. Any comments from any of my colleagues, my team members who are involved in the care? Okay. So thank you very much for all of you for coming, and look forward to part 2 of this presentation at another time. Thank you.
Thank you so much, dear Philip Finny, sir, for that wonderful presentation, and the whole multidisciplinary effort is commendable. And thank you all for coming. It's a packed house, and it's a joy to see this at our own BCMCH. So have a wonderful day. Thank you all.